Hyperemesis is, or what I've spent the last 4 years researching. Hopefully this short presentation will shed some light on that. So what is Hyperemesis gravidarum? It is a severe complication of pregnancy which causes vomiting up to 50 times a day or more, constant severe nausea, retching, headaches, fatigue, dizziness, a warped sense of smell, overproduction of saliva, and various other horrible symptoms. It leads to rapid weight loss, dehydration, and malnutrition, and it can have an understandably negative effect on one's mental health. I suffered with this. That's me in the middle picture in hospital at 19 weeks pregnant with Patrick, having lost over 2 stone in weight, and I'd been bedbound for 3.5 months by then. Prior to the invention of IV fluids, it was a common cause of death in early pregnancy. And still now, even in high-income countries, there are occasionally maternal deaths from HG, and certainly there is a significant amount of infant loss from the condition. Yet, despite the heavy toll that HG has on families, research has been seriously lacking over the last few decades, even in comparison to other pregnancy conditions. There's a number of reasons for this, including tenacious stigmas regarding both the cause and the treatments. And even now, there are some healthcare professionals out there who will tell sufferers that they simply don't believe in it and would rather refer for a termination than to provide a safe and effective treatment for it. In addition, what research there has been has often not been particularly helpful, and it's been hampered by problems surrounding definition and ways of measuring outcomes, which is in part simply due to a lack of listening to those affected. So the aim of my thesis was to help build the foundations of research by raising the position of patients' voices within the academic research arena, so that we can ensure future research truly benefits those who need it and use our precious finite resources more effectively. So now I'll talk you through the chapters of my thesis. So I started with a systematic review of qualitative evidence, which follows a fairly new type of research method. I searched the literature in a systematic way to identify all the articles that had been written to date where women described their experience and the impact it had on them. Then I assessed the quality of the research articles and excluded those which were not good enough, including one of my own that I'd written in 2014. This left me with 9 articles. I synthesized these, pooling the results and identifying new themes which represented the pooled data. Unsurprisingly, no positive effects of the condition were identified at all, although women did express that normal morning sickness was considered positive and often welcome, particularly after a miscarriage or stillbirth. The themes that emerged from the pooled research were social isolation, an inability to care for oneself and others, or a change of role, negative psychological effects, and a sense of dying, suicidal ideation, and termination. And there were 2 sub-themes related to well-being, including a loss of earnings or employment, and changes to family plans. Here are a couple of the representative quotes from the research. As far as other women in the public and other people, they think it's all in your head. They don't understand why you're so sick, because they weren't sick, they think you're just weak. It was so bad, I was even thinking about getting an abortion because I couldn't endure it anymore. I thought this is not worth killing myself over. So following the publication of my chapter 2 article and the publicity that ensued, a reporter from the BBC approached me about a research project to identify how common termination and suicidal thoughts were amongst those suffering with HG. So we conducted a large-scale survey of people who had suffered in the last 5 years, and over 5,000 people took part. This represents the largest survey to date of HG experiences and demonstrates that 5% of the participants had needed to terminate an otherwise wanted pregnancy. Over half had considered terminating. A quarter occasionally considered suicide as a way of ending the suffering, and 6.6% regularly considered suicide. The worse someone's symptoms were and the poorer the care they received, both in the community from their GPs and also in hospital, the more likely it was that they would terminate the pregnancy or consider suicide. In this survey, we also had open boxes where patients could share their experiences. This produced a vast amount of rich data which was analysed for themes. Here are some of the experiences of people who took part. At the point of termination, it was either an abortion or suicide. My family thought I was being lazy and just needed to get out of bed. And after trying for a baby for years and resorting to IVF, I struggled with feelings that I wanted to die. On this slide of women's experiences, you'll notice a recurring theme of not being able to have subsequent wanted pregnancies, and it highlights the need for a greater understanding of the chance of HG reoccurring in future pregnancies. I've been sterilised because the thought of another pregnancy with HG terrifies me. A further pregnancy would kill me and risk my marriage. I'm terrified of having sex despite having the coil inserted. I cried for days when I found out I was pregnant. I really had no idea how we would get through it. And I always wanted a big family, but if I were to become pregnant again, I would terminate immediately, something I would never have considered prior to suffering with HG. So this theme leads me on to chapters 4 to 6, which focuses on the chance of HG recurring. In chapter 5, I systematically reviewed the current evidence for reported recurrence rates. 5 studies were identified, but because their methods and their definitions were all so different, we weren't able to pool the data and reach a more accurate rate. So the reported rates came out as between 15 and 81%, which is clearly a huge variation and far too great a variation to be basing life-altering decisions on. So after this, we conducted our own study where we followed up women who had taken part in a randomized control trial conducted by colleagues some years earlier. We recontacted these women who had been diagnosed with HG to see if they'd gone on to have further pregnancies. And if they had, then had they suffered HG in them? 73 women were able to be followed up, and of them, 35 had gone on to conceive again. We identified an 89% recurrence rate, which is the highest in the literature to date. Of the 38 women who had not had a subsequent pregnancy, 24 of them stated that this was due specifically to HG. And of the 6 pregnancies without any sickness at all, only 1 was actually a viable pregnancy, which resulted in a live infant. So having established that HG is a really terrible condition, affecting people's lives, not just during pregnancy, but potentially for many years after, I set about looking at what research is most needed to help women and to help their doctors to be able to treat them. So first, I established a steering group of totally awesome people, including patient representatives and a number of healthcare professionals from a variety of fields and representing different organisations across the globe. Many of them are in the audience. So we had decided to follow a methodology that's established by the James Lin Alliance, which is specifically designed for this purpose to set research priorities through patient-clinician collaborations. So we had an independent James Lin Alliance advisor to facilitate and oversee the process. So the steps of the James Lin Method involve collecting a huge amount of questions from people that have been affected by hyperemesis or the healthcare professionals caring for them through an online survey. We then refine the questions to make sure that each raw question is represented. After that, we check the evidence to see if any of them are in fact already answered. And this let us rule out one question regarding whether HG is associated with an increased chance of carrying a female fetus, which it is, but only very slightly. So if you have HG, you've got approximately a 54% chance that it's a girl and a 46% chance it's a boy, which is pretty close to 50-50 really. But this means that we no longer need to spend time, money and resources on trying to answer that question. And it's another good example of research being done without necessarily a huge benefit to patients, because it's not like we can choose the gender when we're conceiving. So after that, we then conducted another survey that allowed people to rate how important they thought the questions were on a scale of 1 to 10. This enabled us to narrow the list to 26 unique questions, which were then further ranked to create a top 10 list at a workshop in Amsterdam. And these are our top 10 priority questions, which hopefully will help us to direct our precious finite resources to research that's really going to truly benefit those affected and help healthcare professionals to treat it. So right at the top there is, can we find a cure? And hopefully that's not too far out of the realms of possibility these days. Finally, and very briefly, we then mapped the published evidence addressing one of the aspects of one of these questions over the last 10 years. So this involved screening 624 full text articles and extracting data from 406 articles, which is a fairly major effort. We found that some questions had a lot of studies, particularly case reports and sort of opportunistic type lab studies, which are very numerous but aren't particularly helpful in actually answering questions. And some questions had almost no research at all, such as, can we prevent HG? So this map, this is the map that's produced by that. I realise you can't really see it on the screen, but it is available online with that link on the left. So if you wanted to check it out, you can click on all the different subcategories and get the references per question. So hopefully that will help researchers going forward to reduce research waste through repetitive studies and so on. So thank you all for listening. That's the end of my presentation. I don't know what time it is, but I think the beadle comes in at some point.
Thanks. We will wait some minutes and then we will start with your position.
Dear candidate, thank you for your presentation. Are you ready for your defense?
I am.
Okay, good luck. And when everybody's present, I'll give the word to the rector.
Thank you. Ladies and gentlemen, welcome to this special meeting of the Doctorate Board of the University of Amsterdam on the occasion of the PhD defense of Mrs. D. Dear candidates, to open the discussion, please read aloud the first part of the formula.
By the authority of the Rector Magnificus and the Doctorate Board of this university, I shall, during this hour, in order to obtain the doctorate, publicly defend my thesis entitled Prioritizing Patients in Hyperemesis Gravidarum Research. I entreat all those who wish to voice criticism of the contents of the thesis to do so in a truthful and lucid manner, so as to provide an opportunity for an ordered exchange of views.
Thank you. So now we will start with the opposition, and you will start with your defense of your thesis. And we will start with Professor Peikert. She is a professor of obstetrics in the University of Amsterdam. Professor Peikert, the floor is yours.
Thank you. Dear candidate, by virtue of my right and with permission of the Rector Magnificus, I would like to discuss your thesis. First of all, I would like to congratulate you and your supervisors with this work. This thesis is the result of an enormous amount of work in a field that is not very sexy, or that is not a very sexy or fulfilling part of obstetric medicine, and is frequently neglected or overlooked. Patients may be seen as a nuisance that should get their act together and get over it. Thus, it's a field that requests a fair amount of patience and tender love and care from the caretaker, being either a midwife or a nurse or a doctor. Your work is very extensive and covers different aspects of Hyperemesis gravidarum and is probably a reflection of your energy. I have read your thesis with pleasure, and I'm happy to be able to discuss a couple of items here today. Let me see. Since my work is mainly in fetal medicine and counseling parents about the possibility of terminating a pregnancy is a weekly occurrence, it may not come as a surprise that I would like to question you in that direction. You state that hyperemesis gravidarum is present in approximately 1% of pregnant patients and has a detrimental effect on physical and mental health. In the Netherlands, this would be 1,700 patients a year. Further, you state that termination of pregnancy is reported in approximately 10%. In your questionnaire in chapter 3.2, you found 5%. And if I'm correct, in chapter 6, the follow-up of the mother trial, 9 out of 73 women considered termination, which is around 12%, but only 1 actually did, which is 1.3%. So that would be between 17 and 170 terminations of pregnancy because of hyperemesis in the Netherlands per year. In my clinical practice, I've never encountered a woman wanting to terminate a pregnancy solely on the basis of hyperemesis, but I do encounter women that use hyperemesis as an additional argument to terminate a pregnancy. It's the last push and sort of helps in decision making. So my first question is whether you believe there is an actual direct causality between hyperemesis and termination of pregnancy, or whether women that terminate these pregnancies are already ambivalent and use hyperemesis as an argument to justify their decision to terminate their pregnancy.
Highly esteemed opponent, thank you for your kind words. I have no doubt that hyperemesis is a direct cause of termination in a huge amount of the women that are suffering with hyperemesis. The original 10% statistic came from some research I did through the charity a number of years ago, I think about 8 years ago. And again, was people who had suffered in the 5 years previously. And in chapter 3.2, we conducted a very similar survey, and that rate seems to have come down in the last few years to around 5%. And I like to think that that's largely to do with the work that the charity that I run is doing, in that a lot of the people who contact the charity are at that point of terminating an otherwise wanted pregnancy. And through getting support through the charity, they're able to continue with the pregnancy. We get weekly feedback from sufferers with exactly that if it weren't for the charity, they would have had to have terminated. Women in 3.2, they specified that it was specifically because of hyperemesis and that these were otherwise very much wanted pregnancies. I also know people who have conceived through IVF. It's been that much of a wanted baby, who have then gone on to have to terminate because they simply can't tolerate it. And I suspect that the reason that you perhaps don't come across that very often is because you're treating these women extremely well, and they're reaching you. So by the time they're reaching you, that isn't the reason that they're needing to terminate. Unfortunately, a lot of the people who terminate, they never even reach secondary care. They have barriers at primary care where they're told that there simply is no treatment and there's no point in sending them to hospital.
So if I may interrupt you, do you believe that women that decide to terminate a pregnancy, or actually who did terminate their pregnancy, do you believe that they received inferior care to those that considered it but didn't do it, or women that actually never consider it but do have hyperemesis?
Yes, I do. I think inferior care is the main driver for termination of pregnancy related to HG. I think there are very occasional cases where people have to terminate because the symptoms are so severe. But the vast majority of the cases, it's because they've received inferior care. And running our helpline, it's really sad when we get a person who's terminated and then only afterwards realize that there were all these other treatment options that they could have been offered but weren't offered, and they didn't even know about them. And that's really upsetting.
So what is the minimal treatment? What is the minimum you should do for these women?
The absolute minimum would be to get them on some medication, and if they're dehydrated, rehydrate them. But if it's someone who's considering a termination, then I think why not try all of the medications we have out there and treat it as aggressively as possible. You know, the harm from a termination is final, and that's the end of that. Whereas by combining a series of medications and trying everything we have in our power to help her through it, and then, you know, charities being able to provide the emotional, social, psychological support to get through a horrific condition. I think that's what needs to happen to prevent people from having to terminate desperately wanted babies.
Yeah, but then you have these women that actually do receive all the treatment and they're still very, very sick. And how do you counsel these women? How do you get them to pull through? Because sometimes it may take weeks, you know, as you already showed a picture of yourself at 19 weeks. How would you encourage these women to pull through? What can we offer them? Where can we send these women to? I mean, you have a charity, but where do we? I mean, we can't send all these patients to Dr. Painter in the Netherlands.
You could send a lot of them to Dr. Painter. And there is a charity in the Netherlands as well, the ZEHG charity, can help to support these patients. And it's really difficult. And I think being honest with them is really important, and explaining that we don't have a cure and these medications are just palliative. And then for some people, they're not even particularly effective, and that it is just a really hard slog to get through. But being honest and open about that, and not giving false hope, and just validating the condition, making it clear that it is a really awful condition, but that you're going to do everything you possibly can to help her. And, you know, if she's suffering psychologically, then looking at it from a mental health point of view, referring to perinatal mental health, and so on. I think just a holistic, joined up, validating approach to treatment is the only thing we can do. And sometimes it's not possible. Sometimes we do have to terminate.
If you would have the opportunity to repeat your questionnaire, and because I would be really interested if, you know, I agree with you that if the hyperemesis is super severe, that it's that might be a reason for termination. But I also do believe that women that are actually considering a termination for social reasons also need justification. So what would your questionnaire look like? How would you like to research whether there is actually a causality between hyperemesis and other issues that may be able, you know, to
and
you understand what I'm saying?
Short answer.
Okay, I
Please
think
short.
that for different women, there's very different reasons. You know, if your house and job is at risk from being off sick, then you're going to have a lower threshold for terminating, as opposed to someone who's financially secure and has childcare and so on. So I think really good qualitative research would do wonders in this field, actually, and actually interviewing sufferers of why they've terminated and how that's affected them.
Thank you so much. I'll return the word to the Director. Thank you. Thank you.
Thank you, Professor Prijkert. Then the opposition will be followed by Professor McAuliffe. She is professor also in obstetrics at the University of Dublin. Professor McAuliffe, the floor is yours.
Dear candidate, by virtue of my right and with permission of the Rector Magnificus, I would like to discuss with you the contents of your thesis. I have requested the administrator of this call to turn on my video, so apologies that you're not able to see me, but I was here a minute ago. I enjoyed reading your thesis, candidate, and it was certainly a comprehensive approach, really highlighting women's views and women's input into this condition. I would like to congratulate you on your work highlighting HG as an important condition affecting women and their children. I would also like to continue the questioning of the previous examiner on the questionnaire, which was a very comprehensive piece of work reaching out to more than 5,000 women. And I would like to start by asking you how representative you feel the respondents were of the general pregnant population and how you would go about assessing that.
Highly esteemed opponent, thank you for your compliments. I sadly don't think it is particularly representative because it is predominantly white, middle class, educated people that are taking part in that. And that's not representative of our population. And it's a real challenge to be able to access the people who we really need to be accessing to understand their experiences. I suppose one thing that's striking about that is that, you know, if this is the experiences of our white, educated, middle class, married women who are the correct reproductive age for according to society, and they're struggling to get good care and treatment, and they're facing these challenges with hyperemesis. You can only imagine how much harder it is for people who, you know, for young mums, for people who struggle with financially and with education, or where English is their second language and they're trying to navigate the UK healthcare system and so on. So I don't think it is representative, but I think that it's striking how bad it is for even our sort of most privileged of society.
And is there any evidence that there are ethnic differences in the experience of hyperemesis?
There's mixed studies on this. So some studies have suggested that there's a higher incident in Asian cultures and ethnicities, but then there's equally contradicting evidence from about other ethnicities. I think what is clear is that it occurs in every ethnicity and around the whole globe. So it's not any particular culture or type of person that suffers it. Anyone can be struck by it.
Thank you. I was very taken by a 25% rate of occasional suicidal ideation, and one could appreciate that experiencing hyperemesis gravidarum would or may result in ambivalent feelings of the mother towards the pregnancy. Is there any evidence of an association between hyperemesis gravidarum and postpartum depression and difficulties with bonding with the child after delivery?
So there has been some quite good quality research on this, and there is an association with post-traumatic stress disorder after pregnancy and a higher incident of postnatal depression for a variety of reasons, and largely associated with the care they experienced during the pregnancy. However, maternal attachment there's evidence that during the pregnancy, women don't feel particularly attached to the baby, and struggle with feelings of that they're, if they don't love the baby now, how are they ever going to bond with this thing that's making them so sick? But what the evidence shows is that actually once the baby is born, they are equal, if not have stronger attachments to the baby after the pregnancy. And I think that's really reassuring for women. I know that when I was pregnant, I worried that I just hated this thing inside me in my first pregnancy. But actually, once they're born, it's the opposite. It's, that you feel like you've really fought to get them here, and feel even more sort of attached to them. And there's pretty decent evidence for that now, which is encouraging for our women.
Thank you. And I just wanted to explore with you, are there any risk factors we could identify before pregnancy or very early on in pregnancy, highlighting women who may develop hyperemesis? Because my impression is that many women are expecting some morning sickness, but when they have it severe, they're really not prepared for it. And I think that's part of the difficulty that they experience, is that they're really not prepared for how severe it is. Are there any risk factor tools that we could apply before pregnancy or very early on in pregnancy to highlight an at-risk group who we could then perhaps manage in a more proactive way?
So there's been quite a lot of studies looking at pre-pregnancy risk factors, and the vast majority of them, there's really not much of an association. However, if your mother or sister suffered with it, then you do have a substantially increased risk, and those women should be prepared for the fact that they are highly likely to have it. And the other one is if you've had it before. And that's really the biggest risk factor. If you've had it once, you need to be prepared for the fact that it's going to happen again. And so it's frustrating when we have women calling our helpline and they've been told by their doctor, oh no, your risk factor is the same as the general population, you might not have it again. In our original termination survey, we even had a woman whose doctor had advised her to terminate the pregnancy on the basis that she may not get it in the next one. And actually that's, as we've seen in my other chapters, you've got like an 89% chance of recurrence. So that's just really bad advice. But yeah, also if your mother or sister had it, that's a good group of people that should be sort of prepared for the fact that they're more likely to.
So what interventions then would you offer to somebody with family history or previous experience, either before or early in pregnancy, before the symptoms develop?
So we really need a lot more research on this. And in my evidence map, as I said, there was only 2 papers identified on prevention of HG, which is largely about preventing it from recurring in another pregnancy. But what there is slightly hopeful in that early proactive treatment and preemptive treatment, actually starting antiemetics before you even get sick, possibly can improve the overall severity of the condition. It's not realistic to think that it's going to prevent it completely, but it certainly could take the edge off it. And I think that's really important, that pre-pregnancy counselling. The other thing is to tell women to prepare sort of socially and through their family, making sure they've got childcare, making sure that they financially can cope with the fact they're going to be off work for however long. All of those things can actually make coping with the pregnancy a lot easier. And I'd really like to see a randomized control trial where we can actually do that. That's not a particularly easy thing to do, but if we had controls that got pregnant without preparation, then we could look at how that pregnancy panned out, as opposed to a group of women who actually have a really solid pre-pregnancy care plan.
And do you think...
Sorry, Dr. McAuliffe, but your time is over.
Okay, thank you.
But thank you very much. Then the opposition will be followed by Professor Franks. Professor Franks is also a professor of obstetrics at the Erasmus University in Rotterdam. Professor Franks, the floor is yours.
Yeah, thank you, Rector. By virtue of my right, dear candidate, and with permission of Director Magnificus, I would like to discuss with you some of the contents of your thesis, but not after having congratulated you with it and involve your co-promoter, your promoter in these congratulations. There are 3 things I like very much about your thesis. The first is the approach. I think the approach from the patient perspective and your advocacy for co-creation between patients and caregivers is for me a value-based healthcare approach, a shift of focus to what truly matters to patients. And that is the way we should go in healthcare in general. The second is the research agenda you've put up. I'll come back to that. And the third, of course, is the topic. And since the beginning of my career, and that's over 3.5 decades ago, I've seen very little, if any, progress in the understanding of this disease, this syndrome, and the way we should treat it. So treatment has been in past years, and you described that in your thesis, sometimes maltreatment or even punishment, and that is a shaming. And I congratulate you with advancing that a little bit. I want to discuss with you the issue of the definition of hyperemesis gravidarum. And in the introduction in chapter 1-2, you write that there is no agreed definition of HG, and according to me, this is a huge problem in clinical practice and also research, including your research. So my first question is, how come that we haven't been able to put up a consensus disease up to now? A consensus definition of the disease up to now?
Highly esteemed opponent, thank you for your compliments and your question. So actually, we do now have a published, internationally agreed definition. We do. About 3 or 4 weeks ago, it was published.
Oh, I missed it.
Which is really exciting. Yeah. And my supervisors were involved with that, and I'm one of the various authors on the paper. And what's really exciting about this definition that we now have is that historically, the definition for hyperemesis was very focused on sort of arbitrary measures that a doctor could do. For example, testing for ketones, which are not associated with severity of hyperemesis and so on, or being admitted to hospital. And, you know, as we know, a lot of women are not even being allowed access to secondary care and are terminating before they've even reached hospital. And so, you know, that's really not a good definition at all, because it depends so much on the subjectivity of the caregiver, of the assessor.
Absolutely.
And it was very much about, oh, we have to do a test to see if we believe you or not about how sick you are.
We need a biomarker. We need a biomarker, huh? Isn't it so?
Well, possibly, but the new definition is much more patient focused. So it's asking about the symptoms and the impact on their life, and then believing them. So, you know, asking like, you know, are your symptoms making it impossible to function day to day? And if they are, well, then that's hyperemesis gravidarum. So the new definition is much more patient focused, and was developed with patients. So
and tell me, does it include also some of the old criteria? So you describe this, the Rcog guideline definition. You refer to that in your work. And that is based on weight loss of 5% or more, and dehydration and electrolyte imbalance, not further specified. Has that all disappeared from the new definition?
It has largely. So you have to have nausea and or vomiting, one of which is very severe, and it needs to be interfering with your ability to eat and drink normally and to function on a day-to-day basis, and then. As an additional thing, signs of dehydration would be contributing to the diagnosis. Yeah. But I think that's a great definition. Just you know, if the symptoms are bad enough,
I agree. That's really believe her. Yeah, that's really exciting. And does it also guide clinical management a little? I saw you showing the adopted, I think, puke index score. It's a nice acronym for this. And I found it remarkable that it only includes patient-reported criteria, so no biomarkers at all, in particular not ketonuria, which is, however, still widely used, as you know, as an important criterion for management decisions in clinical practice up to now. So is this puke score a second guide to treatment decisions as far as you're concerned?
The puke score is useful in terms of assessing whether someone's symptoms are relatively normal moderate or severe. But when you get into the realms of hyperemesis, it's not particularly sensitive or accurate. There is a new one called the HELP score, which is much more sensitive at the severe end of the spectrum. But both of them were designed really for research as opposed to clinical practice. And I think really from a clinical practice point of view, what they're useful for is just as a trigger for asking the right questions. So the puke score only goes up to an option of like 6 hours of nausea a day and 6 times vomiting a day, whereas women with hyperemesis know that the nausea is 24/7, and a treatment could be effective in that it brings it down from 24/7 to having half-hour nausea-free windows through the day, and that would be a really important outcome from the treatment being measured, but it wouldn't even factor on the puke score. But I do think it's really important to get towards asking patients about their symptoms and how it's affecting them, as opposed to things like ketonuria, which I want to see completely abolished and never tested in relation to hyperemesis ever, because unfortunately it's still used as an in-out marker for treatment of whether or not you get treatment. And it's not associated with hyperemesis, and it doesn't indicate dehydration. It can mark malnutrition, but it's not a very effective one for that, and it's not particularly accurate. So I think it would help women to do away with that.
So it's a tool to judge the severity of vomiting in pregnancy. Would you recommend to use it as a standard screening tool, since vomiting and also hyperemesis is not uncommon?
Sorry, did you ask if it can be used as a screening tool for hyperemesis?
Yeah,
I think so, for helping to screen as to whether or not this patient's symptoms are actually relatively normal, and that maybe some first-line treatment might help, or whether actually she's got full-blown hyperemesis. But I think that there could be better ones out there. I think that it's slightly flawed in its lack of sensitivity.
Given the time, I want to shift to another question, if the rector allows me, and that is your research agenda. So I saw this, and I'm very happy with it on pages 148 and 149, the top 26 ranked research priorities. It's an impressive list, and the two that appeal to me are priority 5 and 8, the long-term physical, mental, and social consequences of HD for both the child and the mother. So this is a little Doha thinking, of course, and I like that. Do we know anything as yet on the health risks for a baby from a hyperemetic pregnancy or the mother herself?
Please, candidate,
yes.
Keep it shortly.
Okay, so in terms of the fetus, it's associated with long-term cardiometabolic disorders, as established by my supervisors. It's also associated with an increased risk of autistic spectrum disorders. And obviously termination is a fairly long-term bad outcome. And then for women, we need a lot more research into the long-term effects. A lot of people seem to think that after the pregnancy, that's it, it's over. And actually that's really not the case, but there's a real lack of research in that. And we really, really need to start looking at that.
We're doing nothing with this.
No. Sorry, Professor Franks, your time is over. I'm sorry. But thank you very much for your opposition. And then the next opponent is Professor Kunst. Professor Kunst is a professor of social epidemiology at the University of Amsterdam. Professor Kunst, the floor is yours.
By virtue of my right and with permission of Director Magnificus, I would like to discuss with you, dear candidate, the contents of the thesis. As my previous opponents, I'm impressed by your work with the dedication that you have to this, to the patients, and also the way in which you combine this work with the scientific work. And I also, one of the great values of the thesis is that you have a critical attitude towards the scientific literature, and this is reflected in the introduction, where you evaluated, for example, the literature in 2017 and concluded that less than 10% is perhaps valuable to patients and clinicians. So 19% may be scientific waste. And I think it's important to have this critical view to literature, as I do it for my own previous work, and we may also do it later on with regard to the further empirical work in the thesis. And I would particularly like to focus on the chapter 3.1 and ask some questions that later on people may ask when they want to see whether this paper represents scientific value or scientific waste. So I have a few critical questions to chapter 3.1. The first is about representativeness. We already discussed that it may not be representative in terms of the social composition of the population. Perhaps it's not representative neither in one other aspect, in that perhaps only those women with the more severest complaints and severest disease were more likely to respond to the survey, particularly because some of the respondents, about half, responded only 1 year after pregnancy. Perhaps only those with the more severe disease may have responded. So may this survey not have overestimated the severity of the disease and the prevalence of suicidal ideation?
Highly esteemed opponent, thank you for your kind words. Yes, I agree that it's likely to be the people at the more severe end of the spectrum, particularly given that the way the survey was advertised was through our charity networks, and people generally get in touch with a charity when they have more severe and symptoms and so on. However, I think that with over 5,000 people taking part in it, even then, if there's that many people suffering to that level in this country and reporting, such high levels of poor care received and so on, I think that that's still really valuable, even if it's not necessarily entirely representative. That's still an awful lot of people.
Yeah, I agree. So as an accurate estimate of the prevalence rate, it may be in some kind of upper limit, but still it reflects the substantial absolute numbers. So I agree with that. A second question that one might ask is its cross-sectional nature as a survey, and that's of course acceptable. But when you make causal inferences, that may become problematic, and you look at the association between the satisfaction with primary and secondary care and suicidal ideation. You can see a positive association. Inverse association, lower satisfaction, higher prevalence and risk of suicidal ideation. And there's some suggestion in the paper that this may be a causal relationship from bad experiences, greater likelihood to have suicidal ideation. But might the association be the other way around, in the sense that women who have suffered a more severe disease may perhaps have more experiences, more likely to have experiences that may be felt as negative, or perhaps may remember when asked in the survey the negative experiences afterwards. So can you infer from this data any causality?
I think you're right that there may be an alternative explanation to do with the severity of those suffering. Again, I think the numbers are quite important there, but I also think that we just need more research into this, and we need to. It would be good to possibly use more survey techniques, but more carefully designed, so that we can start to look at those causative things. And what defines bad care? For one person it might mean one thing, and for someone else it might mean another. So without exploring what good care and bad care is, it is very difficult to pinpoint that. However, I think that it's certainly representative of from my clinical practice of speaking to 3,000 women a year contact our charity, and it is very representative of that. And poor care generally is actually around validation of the actual illness. So we've had people who feel like they're getting good care because their doctor's very empathetic and really validating of the fact that they're suffering, yet they're only on the first line of medication and have been suffering for weeks and weeks and lost a huge amount of weight, and it's not, but they feel like their care is good, even though it's like there's an awful lot more that could be done for them. And the flip side of that is we have people saying they're just not helping me, and so on. And yet, you know, when we go through what treatment they're having, actually they're getting everything there is to have. But because the staff is sort of not particularly validating and so on, and are a bit dismissive in their attitude towards them, they feel like they're getting bad care when actually they're getting really quite good care. So I think, you know, we need more exploration of that really, and further research.
Yeah, thank you. If can I ask one more question? Then
A short one.
Yes. I noticed that in your answers, so I agree with what you say, and I see what convinces me in that your answers, you refer to the experiences of the women, including you sometimes refer to the experiences of yourself. That raises to me the questions when we should not invest more time and more money in qualitative research, because then we come close to these experiences rather than surveys. So would you, if you would invest one more in some kind of, in the topic covered by chapter 3.1, would you do it in a survey, or would you really do a full-blown in-depth analysis, qualitative analysis?
I would
Please,
love,
shortly.
yeah, I would love a big, good quality, qualitative survey, qualitative research project, really looking at women's experiences. But unfortunately, they cost money, and there's not a lot of money in this field.
Okay. Now, that's a good suggestion for any internship from any medical students to be remembered by any of us. Thank you for it. And would like to give the word back to the chair.
Thank you, Professor Kunst. Then the opposition will be followed by Dr. Aerts. Dr. Aerts is working at the Amsterdam University Medical Center as an oncologist. Dr. Aerts, the floor is yours.
Dear candidate, by virtue of my right and with permission of Director Magnificus, I would like to discuss with you the contents of your thesis. Also, I would like to congratulate you and your team for the terrific work you've done. I'm really passionate about bringing the patient perspective into research and healthcare. So I really hope you will continue your work after this defense, because I think the community would benefit from it. I would like to ask one of your paronyms to read out your proposition number 5. So it's one of your paronyms.
Proposition number 5.
Able to do that. Yeah.
There is a need for a holistic and compassionate approach to HG treatment, which acknowledges the profound effects of the condition on people's mental health.
Thank you. Because I would like to hear your thoughts about, well, you with the previous opponent, you already mentioned it a little bit, that you think that the delivery of care, or how empathetic a clinician is, could, well, make the impact of women's lives a bit, of the disease a bit better. And therefore I was a bit surprised, or it was remarkable to me, that in chapter 7, where you did tons of work in getting this top 26 priorities, that most of these priorities were more or less outcome indicators. So how can we improve outcomes of treatments or things like that, instead of process indicators? So by process indicators, I mean how we communicate with women, how we should make care more accessible. Wasn't it mentioned at all? Or could you maybe reflect on why these kind of indicators are lacking, while in the rest of your thesis, these, well, you mentioned them, was very important?
Esteemed opponent, thank you for your appreciative comments. Yeah, so there were questions like that in the larger body of work. So within within the 65 indicative questions that were established. However, it wasn't up to me how they got prioritized, and it was through a survey system. And I think that possibly people felt that we need to be answering these questions before we can then even, and also possibly that if some of these questions got answered, the better care would come with that, because awareness would be raised anyway. But there were questions on the education of healthcare professionals, and about access to services, and about service design to make them more approachable for women, and so on. But they weren't the ones that ended up getting prioritized. But I do think that by focusing on these priority questions, it will have a positive knock-on effect overall anyway, because it will raise the profile of the condition amongst healthcare professionals.
Yeah, I agree. But by the time that we're still lacking these results, I think something is that we could change is maybe the process or how we communicate with these women, or how would you suggest maybe that we empower women to give raise to their voice, how they suffer from the disease in the consultation room with their doctor? Is there something you would recommend the patients or the women while we're still waiting for those results?
Yeah, I mean, it's really difficult. It's something that I do a lot of clinically, like advising women on how to advocate for themselves. And it is very difficult. There's a power dynamic between healthcare professionals and the patients. And when you're so sick that you can barely talk, it's very, very difficult to sit there and advocate for yourself. And I think that that's not just true of hyperemesis, that's true of all sorts of conditions. Question 2 of my priorities is around the effectively managing HG. And I think that research into how healthcare professionals communicate with their patients and approach treatment can come under that. So we could be looking at research into this topic that you're asking about under the header of question 2, because it does refer to sort of the psychological support as well, and validating patients and how the healthcare professional approaches them. It comes under that umbrella of psychological support for the sufferer.
Yeah, thank you. Then I would like to move to another topic. I mean, it's all related, of course, and that's about the involvement of patients in research. Because I think it's wonderful that we need to that you involve patients to identify those gaps. I think we need to research something that's relevant to patients. And in the Netherlands, we also see that there's an increasing demand for involving patients in research, but sometimes I feel it's more kind of ticking a box. So we ask a patient to have a look at a document or anything like that. So could you maybe share your thoughts about what you think is the overarching goal of patient involvement in research and how we can achieve that goal?
Yes, I can. So I think that patient involvement needs to be complete and throughout the whole process, from the original asking of the question, making sure that it's a relevant question that needs to be asked, and that it's one that patients, the design of the trial is one that patients are going to be involved with. It's no good looking at a patient information leaflet for a study that the patients turn around and go, but no one's going to agree to go into this because it's designed so badly. I don't want to say that it's necessarily designed so badly, but an example of that within the hyperemesis world was the Empower study that went on in the last few years, where right from the very start, patients were saying, this isn't the right way to try and answer this question, and it's not a particularly helpful question. And patients aren't going to be willing to take part in this because it's got a placebo arm and because it's not particularly relevant, and they're gonna know what treatment they want. It also didn't recognize what was going on out in the community. It was looking at a secondary care intervention for 2 drugs opposite each other. And it just wasn't reflective of what was really going on in the world for HG sufferers. And so it ended up just being a huge waste of millions of pounds. An example of how patient involvement did manage to make the very best of it, even after they'd ignored our advice and ploughed ahead with it anyway, was that the initial acronym for the study had been going to be EAT, E-A-T. And the patient community were able to say, it's so inappropriate and cruel that no one's going to sign up to your study. And then it ended up being called Empower instead, which was a far more appropriate name. But sadly, it failed anyway because of the problems that we pointed out with how you were going to recruit for it. It was far too much to expect a patient to get involved with, and they needed to simplify stuff and be asking a far more relevant question as well. Yeah.
Can I add one more short question? In addition to this? Yeah. Yes. So, because then my question is every patient with experience with a certain disease, and in this case, HG, is that person trained enough or experienced enough to be involved in research, or do they need training, or how do we make experts to be involved in research?
So I think no, not everyone's going to be able to, and not everyone's going to want to. But I think that there is an awful lot more we can be doing amongst the research community to support and encourage patients to take part in it. I know in England, the NIHR have developed a subcategory called Involve, which provides training for patients to be involved.
And you can finish your answer.
They provide training for patients to be involved in research development.
Thank you.
Okay, thank you, Dr. Arts. Dear candidates, the discussion is closed now, and I request you to read the second part of the formula.
Having thus concluded the defence of my thesis to the best of my ability, and pending the decision of the doctorate committee, I should like to express my sincere thanks to my esteemed supervisors in particular, as well as to those who have so courteously brought forward their criticisms, and to all those who have honoured this ceremony with their presence.
Thank you. The committee retires for deliberations, and we will come back. Esteemed candidates, after due consideration of the thesis you have submitted, we have decided to grant you the doctorate degree. Professor Rosenbaum is authorized to confer this dignity upon you in a customary fashion. Professor Rosenbaum, the floor is yours.
Thank you. I most willingly accept the task assigned to me by the Rector Magnificus of the University. By virtue of the power conferred on us by law, and in accordance with the decision of the Rector and the Doctorate Board of the University of Amsterdam, I hereby confer upon you, Caitlin Rosa Dean, the degree of Doctor, and grant you all the rights pertaining hereto by law or custom. In evidence hereof, you will be presented at a later moment with the degree certificate signed by the Rector and supervisors and confirmed with the Great Seal of the University. Having thus fulfilled the task assigned to me, I have the honor of being the very first to address you as Doctor and congratulate you with the dignity conferred to you. Dr. Dean, dear Caitlin, well done, congratulations. I am so very proud of you and the work that you've done so incredibly passionately. It's been a real joy and a great privilege working with you and seeing you grow and develop as a scientist, using your personal experience to drive your professional work to make the reproductive world a better place for current and for future generations. The motivation and drive you have has consistently been fueled and also pruned by an equally motivated, driven, dedicated, and passionate woman, your supervisor, Dr. Rebecca Painter, who I now give the word.
Thank you, Professor Rosenbaum. Esteemed Dr. Dean, dear Caitlin, my very best wishes on reaching this milestone, a PhD in medicine, and as expected, you did an outstanding job in the defense. Although we can't hear them here on Zoom, I know many people all over the world have been cheering you on from the sidelines today, as you rewarded for what can only be called your incredible achievement for the field of Hyperemesis gravidarum. In terms of preparation and stress levels, defending your PhD is a bit like preparing for your wedding. To follow suit, I'd like to take you back to when we first met. And as so many of the best relationships these days, ours started online. I tweeted at HG patients to tell me which outcomes mattered to them most in HG trials. And you, Twitter handle spewing mummy, answered to my great delight. I didn't know you were in the audience in 2015 in Bergen at the No Hype conference, as I presented the rudimentary plans for our HG core outcome set and definition initiative. But soon enough, I got to know you after footing an astronomical bill for shouting you and the other patient reps, who I'd recognized to be by far the most fun group of people at the conference, a round of Norwegian gin and tonics. I found out that you led pregnancy sickness support, PSS, and had published a number of books on HG, had conducted research through PSS, trained healthcare professionals on HG management, were a regular on TV and radio, and had won several nursing and charity awards. That evening, I got to know you as a woman who was driven, knowledgeable, very well connected in the field, a team player, but definitely a leader, and one with a clear vision of the way forward for HG patients. And someone who would not take no for an answer, who had great impatience to have HG solved. Exactly what I was looking for in my research team. Yet somehow, and I don't know if it was the fact that you're a nurse and not a doctor at the time, or that you had struggled with dyslexia, I don't know, but you had thought that science was not for you. I hope now that you can look back and see that your assets made you the only person who could have ever done the outstanding job that you've done in the past 4 years. Maybe our conversation did spark something, because the one thing standing between you and a PhD was a master's degree, and without any encouragement on my part, you gained your master's just a year later, and you'd started your PhD at Plymouth University. Was I about to lose you to Plymouth Uni? I wasn't going to stand for that. At ICHG 2017 in Windsor, I had to take drastic measures to win you over. I proposed, and she said yes. As is the case for most couples, it's not all joy and glory. Writing a thesis is no different, and yours too had its ups and downs. Besides the fact that your family has an amazing propensity for exotic serious illness, we're talking about meningitis, leptospirosis, and West Nile fever, you've dealt with some other serious setbacks during your PhD. I just want to pick out one, which is not really related to any of the chapters in your thesis, but it does illustrate how Dr. Dean rolls. In mid-2019, the EMA announced that ondansetron, one of the most effective drugs used in hyperemesis, was to receive a warning label status equivalent to that of thalidomides. Ondansetron has been found to be associated with an increased chance of facial or orofacial clefting, adding 3 in 10,000 cases, an effect size which many sufferers of HG find reassuringly tiny. Knowing that lack of access to ondansetron would mean more people with HG would suffer worse and may even have to terminate within days, you had the HG community together. An official letter of objection to the EMA had been drafted and signed by big names in the field, and a call with the EMA Practice Guideline Committee had been planned. You called the EMA out over their lack of taking responsibility for risk-benefit assessments in their guidance in pregnancy, and nonetheless, the EMA would not alter their directive. You were destroyed and furious over this, and shortly afterwards, the world was swallowed up by the COVID-19 pandemic, which cut you off from your lifeblood, which is social interaction. And you told me in that period that you wanted out of HG research after your thesis had been completed. Dr. Dean, your PhD brings with it a great obligation. There's no one else with your toolbox, experience, guts, and personality. You're now as well equipped as they come to take the HG field forward. You have the leadership qualities. You've demonstrated the academic qualities necessary to take HG research out of the dark ages of opportunistic nonsense. Whether you like it or not, you are now going to have to see this thing through. Out is not an option. Plus, I know how much you like to kick ass and how amazing you are at doing it. So it turns out that our online flit with science has turned into a serious lifelong commitment. I, for one, am feeling incredibly proud of you today. And you know, Rob, Alfie, Patrick, Orla, your family, the global ICHG community, PSS, friends, mates, and fellow MILFs all feel just the same way. Through your hard work and commitment, you've earned every ounce of praise, of the praise and the fun that you're about to have today. Enjoy every minute. He's looking at you, Dr. Dean. Thank you. I'd like to hand back to Tessa. Sorry.
Regard the obtained dignity as an honor and a privilege, and never forget the attendant responsibilities which you now bear towards science and society.
Thank you, dear doctor. It is a very pleasant duty, most learned scholar, to congratulate you, also on behalf of the doctorate board of the University of Amsterdam, on this newly acquired honor. And hereby, I declare the ceremony closed. But don't switch off now, since the opponent has now the opportunity to say some informal words to you, of course, in order of the opposition. So I will give the floor to Professor Pijkert.
Dear Dr. Dean, dear Caitlin, I had the pleasure of meeting you in person a couple of years ago, pre-corona. And I was very, well, not surprised, well, maybe happily surprised by your enormous drive and your passion. I don't have much to say. I think Rebecca told you that needed to be said. I can't add much to that, but I would like to say one thing is that you really, really should be very, very proud of yourself. Congratulations.
Thank you.
Next is Professor McAuliffe.
Dr. Dean, I'm delighted to address you with your formal title. And this is an incredibly important day for you, your family, and for all hyperemesis sufferers and researchers. I know a huge amount of your time and energy and thoughts have gone into this thesis, and to be here today awarding, being part of the award ceremony is very exciting. So congratulations. And I'm sorry I can't be with you, but I do hope that we will meet up again very soon. So congratulations again.
Thank you.
Okay, thank you. Then Professor Franks.
Yes, thank you. Dear Dr. Dean, dear Caitlin, also my compliments and congratulations. I think a top achievement, both the thesis and also the convincing defense. So be proud, enjoy today, and I hope to be in touch with you to talk some more on how to involve patients in research, because that is really what we need. Have a good day and hope to see you.
Thank you.
Thank you. Professor Kunst.
Yeah, dear doctor, also my congratulations and also my compliments on the great work that you have done. I only knew you from the book, so I was already impressed by then, but now I have seen your defense, I'm impressed even more. Your co-promoter said that science is now for you, but I hope that all through your work, the science is for all women with RAG, thanks to your work. And I hope you enjoy the day. In the Netherlands, the PhD students make a big party in the evening when they have become doctor, and I hope you will do the same.
Thank you. And then Dr. Aerts.
Very difficult to say something after all these nice words, but congratulations, Dr. Dean, dear Caitlin. We met very briefly by email about the student project. So as I said, I'm very interested in patient participation in research and guidelines and all sorts of things. So I hope maybe we can collaborate a bit on that. But for now, enjoy your day. You can be very proud of yourself. You did a great job, and cheers for later today.
Hey, thank you. Dr. Dean, I hope you enjoy the whole ceremony, and I wish you all the best. And goodbye.
Thank you.
Congratulations, Caitlin. Really well done. I'm so proud of you.
Thank you, Tessa.
Enjoy the party.
Thank you, we will.
Thank you.
Dear Dr. Dean, congratulations also from me. And I'd like to thank all the participants for their contribution. And I think we can now close this, so you can have your party.
Thank you
very much.
Thanks, everyone.
Bye, everyone. Bye.
Bye.